Okay. So as you all know, I'm Maitland trained. I am very heavily Maitland trained. However, I think there are some benefits of teaching you direction of mobilization in the Thompson technique, which will give you this power on specificity in the direction that you mobilize. Because mobilization doesn't really just occur P to A. In Maitland's theory, they have superiorly gliding, medially directed, lateral glides, and so forth. So I think there are some benefits of learning some of the Thompson's technique in terms of its mobilization. The interpretation of it maybe not as much, but for sure I need to teach you all some of that. Okay, so let's just word it as if I have the spine and we have the spinous body, and this has to be in lumbar spine. So your spinous process is relatively somewhere here. Okay, that's your spinous process relatively somewhere here. You have your this that is somewhere around here, and you have to understand that the terminology of the chiropractic or Gonstead technique. Okay, so the first thing that you have to understand is P. I corrected myself. P in the lumbar spine might be just position because they don't believe in anterior subluxations. So we're gonna call P as posterior. Okay, so therefore your manipulation or mobilization is P to A. Okay, so the first word that you have to learn is P. The second is in the rotational plan of the spinous process. So what do we have? Your spinous process can be a little bit more positioned towards the right side, okay, or the left side, depending on the view that you have on X-ray, okay. But say it is going to the right side on your prone assessment, then we will call this R for right, okay. Then the next part is you have a superior or inferior. So this particular spinous process can go superior here. So we then go S versus an I. Okay. From there, you have to think about the position of manipulation. Okay. When your spinous process or your vertebral body is rotated to the right and has a bit superior to it, therefore your convexity, the convex surface of the disc, will be on the right hand side here. Okay, so then your application or contact points will be for the lumbar spine directed pretty much on the same side, so on the right hand side, and you'll be pushing always on the convexity. Okay, you don't push into the concavity because they believe that you are pushing further into sprain. So with that in mind, let's look at PRI. Okay, so if it's a I response, meaning that the spinous process is positioned a little bit inferiorly here. Okay, what happens here is it is positioned like that and down, but it is still convex on the same side, on this side. No, it is convex on the opposite side now. So we have the left side that is a little bit more convex. So as I mentioned before, your manipulation then has to be coming from the left hand side. Okay, there's another theory. So we have learned PR, S or I, PL, S or I. Okay, in the lumbar spine. There's another theory that you can apply into it. It's whereby your direction of manipulation is always towards the vertebral body. Okay, vertebral body. Meaning to say, the position or your contact point, it has to be towards the correction of the vertebral body, not on the spinous process as your only contact point. Because when it comes to thoracic spine, the segment of the vertebral body, but your spinous process is actually about one spinous body below already. Okay, so if you are thrusting on the spinous process in a thoracic spine, your spinous process is angled downwards, so you thrust in this area here, you may not be making the right correction on the vertebral body that you're aiming for. Okay, remember the spinous process in the lumbar spine is probably looking like this. Okay, but the spinous process of a thoracic spine is like this. So therefore, you cannot be judging your contact point is always on it. You only use the spinous process as a form of assessment, but knowing that when you reach the thoracic segment, your spinous process is a segment below already. Okay? Which means, where are your contact points? So your contact points are usually around the medullary body, around this particular area here. Okay, be it on the same side where the convexity, okay, or when the convexity is on the opposite side, your hand is here. You are not judged by the spinous process. Okay, if that is the way that you want to choose to mobilize. Okay, now what else I need to guide you is, if I am mobilizing this particular thing, I can make it slower. I can do correcting the rotation first. So I'll be mobilizing the spinous process towards this side. Okay, as close to proximal as we can to rotate it here. And I can mobilize it a bit more towards superiorly. So I glide in this corner going upwards this way. If I want to go inferiorly, then I will have to come over this side and I have to guide it down this way. Now when you put the two vector force together, one vector force goes this way to correct it from rotation, and say we are dealing with a PRS, so the spinous process is superior, there's another vector force that needs to push it downwards. So the combined vector force is at this contact point is to push in this diagonal here. Okay? Towards and onto the vertebral body. Now, if it's a PRI, meaning the spinous process is towards the right, but inferiorly, therefore, I have to do a rotational mobilization this way, and I need to do a superior mobilization this way. The combination vector force of it is you have to do one this way, directed like that, and one this way. Or you can just do it this direction if you want to combine. Okay, so it's a very, very mechanical thinking. Do I really like it in terms of the thinking process? No, but what I find is that it is very helpful to reproduce some of the symptoms of our patients. Particularly, you know that it's on L5, but your straight PA does not reproduce the person's symptom. But if you position it correctly in the right direction, you will reproduce some of the symptoms. In turn, your reassessment of it will be different. So the classic examples I'm seeing on this 1 week of playing with Thompson based joint mobilization assessment is, I have two patients in fact. Faber on the right hand side was tight, was guarded, there was a bit of tension around here. And I did a directed mobilization onto the L5 spinous process, which is more on the PL, okay, and one of them was doing a S, one of them was doing an I, but whatever it is, after I purely work on the lumbar spine but on the left hand side, the fiber on this side increases and drop down very freely. I mean, alongside with it, I did some mobilization using the Thompson technique on the ilium, which we'll discuss shortly. Okay, but what this suggests to me is, if I were to treat it in the past, what would I do? I would have freed up the psoas on this side. I've done some SIJ bias treatment because it feels a little bit not aligned per se, and I'll probably find some stiffness around the lumbar spine. But guess what? On this particular patient, I have done it in the past along this way, but never have I been able to just do one mobilization straight on L5, not at ilium at that stage, that the fiber open up very freely. Okay? Convincing the patients, telling you what to do. Okay? So I have follow-up exercises for the lumbar spine. So if it's a pure lumbar spine, in whatever direction that it is, especially in the L4, L5, you can then incorporate your physio understanding to do the pelvic tiltings. So why? Say for example, you have been mobilizing a patient from the right hand side, okay, into a inferior corner. So meaning you're inducing right hand side extension, okay, and you're trying to promote this right spinous process towards the left hand side. So you're getting a little bit of a left rotation and extension component. So now if you break it down to purely in the lumbar pelvic segment, on our pelvic clock, thumb being our 12 o'clock, middle being our 6 o'clock, left hand side, palm being our 3, and this is being our 9. You start by initiating lower lumbar pelvic flexion and extension. What you see, those with compensation will start to do this, and the spine will follow. And you will normally find some compensation in the middle upper back as well. Okay? So once they can segmentally move this segment here, my next exercise for them is to try to get into 4 and 5 o'clock. So when you go your pelvis tilting into the 4 and 5 o'clock, your right side lumbar is going into extension. Your vertebral body is now going into rotation left. Okay? And oftentimes, if I mobilize in that direction, I do this homework. Patient will feel it is stiff to get there. But you know it's no more stiff because I've mobbed it to a point where I can feel that direction is loose. So that means it's a motor control. You start relearning this motor control towards this side. Okay? Then what you do for homework? Homework can be a narrow stance. Okay? Right? Lunges. You're still going into this 4, 5 o'clock through the pelvis. Right? And then if you want a little bit more extension on that same side, you can then take a stick upright, overhead, or dumbbell weights, and the person's more upright. And then when they go down, they're going into the 4, 5 o'clock. As they go into 4, 5 o'clock, their right lumbar spine is going into extension, vertebral body is rotating to the left. And that's how I incorporate physiotherapy thinking into a chiropractic dominant. Okay, I was telling Mao that chiropractic has doing manipulation longer than physio has. I think there are things to learn from them, just like how TCM has been doing needling longer than our dry needling. Okay, now we're gonna go into the ilium now. We know the S for superior, I for inferior, right and left, and so forth. Now we're gonna go into the ilium. This is where Rebecca was talking about elephants when they start drawing the pelvis. Okay. So we have a sacrum, we have a vertebral body, we have a heel, and we have a ilium. Okay. So say now we're looking at a ilium. Ilium can present itself superiorly, inferiorly, or anteriorly, posteriorly. So anterior rotation of the ilium, superior lifting of the ilium, and there's also another one whereby in flare and out flare, but they will probably call it medial or lateral. So that's a lateral when it goes on this side, medial when it goes this side. Okay. Normally they come together AS, PI because of the sacroiliac joint. Okay. They either will have a lateral to follow or medial to follow, but they may not have. Okay. So the direction that we'll be looking at is when we go anterior and superior into this position here, the contact point to correct for the SIJ has two. One contact point is around this particular spot here. Another contact point is around this particular spot here. We then can provide a inferior and posterior gliding. So gliding it back, you can use the drop table and all that, and you can get a sort of like a mobilization into it. I like to tend to hold in a sustained position into those, and you play until you feel there's a bit more give into the sacroiliac joint structures. Same thing for medial or lateral. Medial or lateral, they are relative to S2. So if the space between the S2 to the iliac wing is narrow, they will call it a medial. Okay, versus a lateral where the space is wider, and that is the symptomatic side. What you also have to remember is that if one is going into AS, the other one, when you measure them, will look like it's going into P and I. But which direction should be the one that you manipulate? Then they follow another principle, is whereby they look at the L5. So the direction that the vertebral body is rotated towards is the one that you will have more problem or convex towards. So say for example at L5 segment, your assessment came out to be a PRS. Okay, so the spinous process is positioned on the right hand side and a little bit superior. Convexity is around here. So therefore, whatever finding you find on the right ilium will be the primary one that you do your adjustments or mobilizations on. Okay, so that's a little principles that they will do relative to it. Only then that you might look at some sacral relative to the coccyx or sacral relative to the L5, which I think I leave it up to you all to play. Okay, but now we're going to talk about the ilium being in the medial or lateral. How are you going to manipulate them again? If it's on the correction of the lateral, your mobilization or manipulation can be from just directly on the side of the ilium here and just do a mobilization inside line. Okay, or you can do a mobilization using the hand over the opposite side and pull it back this way. Okay, I'm going to bring your attention to this particular assessment here. So say for example, this particular case has a AS. So it's in a superior and anterior. So that vertebral body is a bit more rotated to the left hand side. So I saw this person, okay? This person presented a bit like that. Pelvis is pointing this way. This pelvis anteriorly positioned a bit more. You measure the right femur that is a bit tighter on the right hand side, okay? And what you will find is stride length in this manner here is wider. So when right leg steps forward, it's wider or longer. Stride length on the left is shallower, okay? So I did the same thing I teach you all. Okay, we start from the pelvic floor, learning the L5 component. Very quickly, I get them to put hands on the front here. Okay, so I said, your pelvis have a strong tendency to position anteriorward here. Don't have to talk about the superior and all that stuff. Okay, so what I want you to be able to do is now take this hand, put it on the bum end. Okay, now what I want you to be able to try to do is when you're stepping forward with your left leg, I want you to drag this left foot a bit longer into extension, and you're going pelvis down and inferior as you're stepping forward. Down and inferior and stepping forward. So every single step that he took, he is now mobilizing the ilium to go into posterior and inferior. Posterior and inferior. So you find that my pelvis is also facing this way. And then, after working on that, I come back. I haven't released anything in the front hip structures. I do Thomas test, it improves. I do Faber, it improves again. So what I'm sharing with you here is let's combine the knowledge that we know of physiotherapy and we use it in gait retraining. We train the person to mobilize in the direction that you have already manipulated. Okay? Or another case that I saw, the opposite. It went into AS ilium, so it's in that position. No, it went into PI ilium. And this one was having some buttock pain, piriformis, straight leg raise was positive and all that. Homework was given by a physio to do figure of 4. Now, when you go figure of 4, you're going pushing the ilium into posterior and inferiorly, which then he says, you're right, sometimes when I do that, it actually made me worse. So you can see sometimes our physio findings, we have to take it with a grain of salt because there are other theories that we don't understand. And when we start looking from another lens perspective, now it all makes sense. Okay? So my request is for you to try joint mobilization using the assessment of the Thompson bias techniques. Okay? And see what results you can find. Because now what I did for this guy was I obviously encouraged him to go into a anterior and superior, right? Anterior and superior. So what do we do? As a homework, I got him to walk backwards, step back. So it's anterior, superior, step back, and come back. Anterior, superior, step back. And he starts to feel this area of the buttock, but not this area of the buttock. We did roughly about 10 to 15 rounds as a form of mobilization. I didn't even lie supine or prone to mobilize him. After 10 to 15 rounds, we did back straight leg raise. It became much more looser. So there must be some sort of mechanical function that's going through the ilium that we are somewhat missing. Okay, so have a play, and if you're interested, I will cover a little bit more towards the upper cervical end of things.